Hi, good after or good morning. It is Friday, April 10th, and we are taking testimony, more testimony on S-142, which was the licensure for internationally trained physicians and med graduates. And we're going to start today with Lauren Lehman from Department of Health. Ooh, thanks for coming in.
Thank you for the opportunity to testify. Get my papers out here. Thank you. So my name is Lauren Lehman. I'm General Counsel for the Department of Health, for the record. And I really thank you for the opportunity to come in and speak to you about S-142. I want to be clear that, yes, we have the Board of Medical Practice in the Department of Health, but we're not always fully aligned policy-wise. They're an independent board. They will also, I think you might be hearing from them later, and they testified in the Senate as well. We're hopefully aligned on, and we're speaking with them this afternoon to make sure that we are aligned on this proposal. But I want to say that the Department of Health is fully supportive of creating this pathway for internationally trained physicians. And we're also committed to developing and implementing that pathway in a way that is ensures public safety and safety for all Vermonters, as well as efficient and effective use for both the state, but also individuals, because the licensing application process is incredibly resource intensive for anybody. So those are our goals. And as you've heard from Mr. Zimmer, the bill that Vermont has is very similar to bills that have been passed across the country. In fact, this bill includes a lot of the elements and the variation. It's included all of them. And so the Department of Health, because this is such a complex area, has reached out to other states to start understanding what their experience has been in implementing these bills. And we're hearing that they're facing quite a bit of challenges as well as time delays. Illinois took 2 years to pass theirs. Massachusetts passed a bill in 2024. They're hoping to begin offering licenses maybe this summer. It's been a lot of, we've heard that in approximately 12 states that currently accept applications under similar license pathways, only 10 licenses have actually been issued. And the challenges are really around visas, establishing standards, because you're building essentially a residency in these healthcare providers. So establishing standards for evaluation and assessment by the healthcare providers, the Board of Medical Practice would be, and also assessing graduate credentials from other countries. So, if we're looking at a list beyond the FMG, that we're having to go into countries, look at their medical school, look at their medical training, and determine whether that's equivalent. These are volunteer individuals, volunteer doctors that are coming in. They don't have that level of expertise, and we don't have that level of expertise at the Board of Medical Practice now. We rely on state U.S. organizations that build residencies, that build medical schools and credential them. There's not a similar organization for all international medical schools and clinical training right now. So those are some challenges. But that said, and it's a new policy. Even Mr. Zimmer was acknowledging this has been the last 5-6 years that these policies, that this process has been adopted by states. And so what the department is asking for is time to learn from that experience, time to learn what the adaptations need to be put in place, time to learn outcomes of those experiences. If we're only getting 10 licensees, where are the hangups? What can we adapt? And so to that end, we've submitted some language to Ledge Council this morning that would remove some of the specificity from the bill and instead authorize both the study and rulemaking for the department on these specific issues. And this would achieve two things. One, it would be the same timeline. We would still have rules by July 2027 and implement by 2028. So we would be committed to doing this and we'd do it. Next January, the legislature would get a preview of what we would be proposing to put in those rules, in that report, that study. It would give us a chance to look at what other states are doing, adopt, give proposals on those methods, and look at some other pivots. It would also give time for the private community to build the infrastructure. What are the best evaluation and assessment standards? Can a third-party credentialing evaluation service come online that looks at international medical schools and clinical training? That's what we did for back in my OPR days. There was this third-party credentialing evaluation service that the boards could rely on to say, hey, this education in Madagascar is equivalent to US education, and have looked through the curriculum and have the expertise, done that verification, so the board can rely on that rather than having it reinvented in our state. So it gives all of that time to happen. We bring it back to you. If this body decides, nope, this is not going the direction we want, you could adopt this specific process in statute at that time, or you could keep saying, this is the way we're going. Let's stick with rulemaking. Rulemaking also has benefits. And we heard that, oh, it's going to take more time. They don't need extra time. We don't need extra time. We're going to fill the same timeline. But the rulemaking, we do feel that it's when it's done intentionally and thoughtfully. It is an equitable system where you can incorporate public hearings, you can attend meetings of community groups, you can get public comment back, you can involve the feedback of all stakeholders, as well as, again, doing that evaluation and be more nimble in the future. Should a third-party credentialer come online, rather than come back to the legislature for a full bill change and process, we could change the rules to reflect that in the licensing process. So again, our proposals, the department would still be accountable. We'd still hit the same timelines, but we'd have more flexible and opportunities to learn from other states' experiences and outcomes, and to incorporate new resources into this process. So this, I also, if you want to discuss the range in costs right now, we don't know. I think that's the other process. There are some. Go ahead.
Before you move away from timelines, I'm confused because you keep saying we'll meet the same timelines, but we'll have more time to bring in these other resources, et cetera. Can you just?
Absolutely. So we'd have more, I guess not more time, more space, because if with the specificity in the bill as it's written, we would still have to follow that kind of process of provisional licensure, visa check, of looking at other countries' medical tied to specific lists of medical schools. So this would remove that obligation and instead allow us to look at what's working and change that process or propose different alternatives to that process.
Can I ask, there's so few people that we even anticipate with this current bill that would be applying. Why could you not simultaneously do this?
Because it's so few people is actually a complication. It's like insurance. You're building an entire system and you have to do it equitably. You can't do it, a license, a professional license is a civil right. And so you can't do it arbitrarily and capriciously. You've got to have a system in place and it's got to be consistent. To do a system, and especially when you're building an educational clinical pathway that is assessing somebody's qualifications and credentials to practice privately, you're building that whole system for two people. Usually when we build a licensing system, the number of people offset that cost, right? You've got 100 people bearing the cost for that expense. In this, we're looking at two people bearing the cost for that whole expense, which means we don't want to put that on licensing fees, which is what we do for other professions. How else do we offset that cost?
Sure.
So that brings me to like one of my other big questions that I had for our earlier witnesses, and that was around the staffing of this. I think can you speak to the fiscal note? Because I know one of our previous witnesses cited the fact that New York is licensing like 80 something people, and they're doing that with 1.5 FTEs. And it doesn't feel like you've recognized New York in their volume that they're doing this at.
Absolutely. So we disagree. They're doing it with 1.5 FTEs. They've got boards, they've got an entire program and division. And what they do is they go and They look at every law school or every medical school. They look at every clinical experience, and then they do a one-to-one analysis. So that's incredibly resource intensive when you're talking about 8 years of educational training and education and training for it to be an independent physician in the United States. Others, I think Washington was also mentioned where they've licensed 50 people. They actually adopted the law that looks like this on March 27th. They had a different process previous to that, which was enabling medical graduates from international medical schools to participate in residencies in the United States. So not be fully licensed, so they weren't building a residency, they weren't building a clinical experience. They were just taking medical doctors and allowing from other countries and allowing them to participate in residency in the United States. And we already have that process too. So they have 50 licensees from that. They have not even implemented this yet.
The last question is, the language that you're proposing seems pretty fundamental to the structure of this bill and implementation of it. Why are you just bringing this to the legislature now and not earlier when it was in the Senate?
I can't speak to that, unfortunately. I could talk to my colleague Jessica. I don't know that we had, we may have just been short on resources ourselves. We have one policy person, now we have two, but until about 3 weeks ago. So I could imagine that caught us up. So I apologize for.
Did someone testify in this bill?
The board testified on it. It came in pretty late and it came in pretty fast and furious. So the board chair did testify on it, but I think we want to clarify the department's position and definitely want a path forward here. And I think we did get an amendment in at the last minute to get the study in. And I think we're taking this opportunity now to ask for the infrastructure around that, right? We want to be able to have more flexibility in the rulemaking process as we've learned from other states, locations and challenges they've faced.
Did you want to, were you all set? Yeah. Did you want to finish? I know.
I was actually going to address the resource issues. So thank you, Representative Rebecca, for letting me speak on that. I also, if we do decide, if the legislature, the committee does decide to stay with the language currently in S-142, the department would like to propose some amendments to it. But hopefully we can work with you and others to move to that slimmer approach.
You mentioned that you wanted, are you requesting an appropriation to do this?
For the study, no.
Okay.
At this time, no, but we would come back next year and the study would let you know, and we'd have more exact numbers then by looking at other states and having done more evaluation of what the resource costs would be. And then we could say we need 1.5 FTE, we need board training, we need this contract with this party, and give you a more detailed accounting of what resources would be necessary.
Can you give us a summary of what the changes that you're recommending would do and change to the bill? Just a summary.
Yes, I will provide written testimony after this, and we've submitted the bill proposal as well, but yes, Representative Black, I will.
Okay. I'm sorry, I feel like I was getting a little lost in your testimony on what exactly you were even asking.
If I could, may I take a summary statement?
Yes,
in case.
that's what I'm hoping that you would do.
Yes, so our ask is to remove some of the detail, the specificity of this bill, and to authorize us to have more general rulemaking and power. The reason for that is we're noticing a lot of states are having challenges implementing this level of specificity. We'd like to bring a study back to you in January saying exactly what we've learned, where we propose to go and what the rules will say. And then at that time, if you want us to give us more direction, we could do appropriations then. If you dislike it, otherwise we would go forward with the rulemaking, no timeline changes.
Any questions for Lauren?
Thank you so much for the opportunity.
And I think we have Dr. McNamara on Zoom with us.
Good morning.
Good morning. Thank you for being here with us and testifying on this bill.
Thank you for having me. So my name is Mariah McNamara, and I'm the Associate Chief Medical Officer for the Medical Staff Services at UVM Health. I also clinically work as an emergency physician at UVM-MC, and much of my role is currently supporting the medical staff affairs, so things like credentialing, privileging, and peer review across our system, including for physicians, RPAs, nurse practitioners, and others who hold privileges. Another role that I have that I wanted to mention in this context is I serve as the faculty leader at the College of Medicine, where I support our global health program. And so I've been supporting since 2012 our student exchange, as well as faculty and resident exchange with other medical colleges globally. I wanted to speak in support of this bill for pathway to licensure in Vermont, because I think it is a meaningful step towards expanding workforce and therefore allowing access. I recognize that small numbers of people can sometimes be challenging from the previous discussion. However, each physician that serves in our community can see many thousands of people, especially where this is a development of that workforce that's intended to really be staying over time. I do believe that physicians that are trained in other places most often do have the knowledge and skills and the building blocks that we need for medical practice. But it's really important, especially when we have people who are coming in from outside of our standard systems, that we have appropriate oversight. And so figuring out some of the rules around and getting into that detail of, what was the curriculum, what is the experience, and that detailed dive can be really important. I really appreciated in this bill the approach of getting a report and doing some of the work to dive into some of those details. I think that is critical to making sure that we have a plan for both the development and support of the individuals to be successful in making a transition to practice here. I would anticipate that people may be coming from a lot of different perspectives and a lot of different backgrounds, and perhaps have a lot of different practice areas that they would be looking at serving here. I think some of that is actually really exciting and could add a lot to our medical community. It also is something that is going to require a lot of thought and deliberate oversight to make sure that it's being done in a safe and supported way. So, in short, I really think this is something that is a supportable direction to go in. I think it's going to take time and it's going to take some work to make sure that we do this well. But I do think that improving our workforce, building our workforce with the eye to improving our access is the reason that moving forward with this type of work is really important. So thank you for giving me the time to share that.
Thank you. Thank you for your testimony. Any questions for Dr. McNamara? Go ahead, Karen. Sorry.
Hey, thank you for being here. Are you already working with doctors trained overseas in the residency program? Did I understand that?
Yeah,
Yes.
We do already have a pathway for people to come from other medical schools. They take their STEP exams and they can join a residence program. And some of them are some of our best residents. They can be wonderful. So we do have that pathway currently. This bill and a pathway to licensure that is separate from a residency entry would require some additional work to be able to set up the standards for that type of program that's separate from a residency. But I think it's important to recognize, especially when you see people who come in with sometimes very extensive experience in an area, going back to do a residency where these spots, we sometimes have residencies that only have one position per year. They're very competitive. They have, the match process that you might have heard recently that they went through. It's not the easiest process for somebody who's trained overseas to enter into. And for folks who are here, we know of a number of people locally that they're committed to being in Vermont. Going through residency is not realistic for both, needing to move potentially, for the requirements around residency, for the time, the financial piece of that sometimes can be challenging. So I think having an alternative pathway opens up our ability to take advantage of supporting and developing those folks as people who can serve here as well.
Great, thank you.
Yeah.
Daisy.
Do you have a program for evaluation and assessment for people who are provisionally licensed?
So we currently don't have provisionally licensed folks that we're bringing in. What we do have is an ongoing program for professional practice evaluation. And so there's some standard evaluative requirements that we have through CMS and Joint Commission. The ongoing evaluation and oversight of practices we call OPPE, and that's a medical staff process where annually we review competency of practice. That's done through some qualitative and quantitative metrics that are fairly standard. Some things are like professionalism, medical record documentation, knowledge and skills. They're based off of our ACGME competencies. So the ACGME is our residency training competencies. So we do have an ongoing process for all of our medical staff for evaluation. We also have, when somebody starts new, the first 6 months, they're under what we call an FPPE, which is a focused practice evaluation. And that's where usually their clinical leader is looking at charts, talking with people about how practice has been going, and that is another standard part of our evaluation process. So there is, and that's for all folks with privileges with full licensure as well. I think what this pathway would enable is to be able to be within a program or a support structure that is in addition to just those check-ins, those standard check-ins of making sure that the metrics align with expectations and that the qualitative pieces of the evaluation, like professionalism, communication, are going well.
So even a more, these people would be under a more rigorous evaluation and assessment process than everyone else on the clinical team?
I would imagine that would be the case for making sure that some of those where we don't have the evaluation process from their medical school rotations or residency rotations and evaluations having a process to be able to kind of make sure that people have come through and have the competencies are what I would imagine would be looked at in the process. I see this as, the residency programs have graduated responsibility, and people move from initially having a lot of oversight, a lot of expectations for, having somebody perhaps at their shoulder, to then being able to have graduated practice where they have to check in, or they have to have somebody there just for a portion of a procedure, for example. I would also see this as analogous in some ways to that process, but trying to do it in a way that really meets people where they're at, given the diversity of where people may be coming into it. And I think that is one of the challenges, and one of the things that should take some time to develop a framework that people can work through, is very similar to what we expect all along the process of developing an independently practicing physician. But I don't like the feeling of saying that they have to do more necessarily. The competencies are the standard competencies, but how we work somebody through developing those skills, getting them familiar with our health system, how to practice within the system and understand some of the local nuances of how things are done, and making sure that they have met all of those competencies we expect everyone to meet, and having a way of showing that, I think, is really important.
Thank you.
Yeah.
I was just hoping, as you're the director of the Global Health Program at Larner, I'm wondering if you, and we had testimony yesterday, whichever day we took testimony on this, and we had just sort of anonymous testimony, but several of them had indicated that they work at EBM Medical Center. And I'm wondering, if in your position, if you are aware of people working in, other types of positions within UVM, and how, if you've interacted at all, and just had interest in what their skill sets or experiences are.
Yeah, I think our global health program that I support is a collaborative program with the branch campus in Connecticut. So I'm actually the associate program director, but I'm the person based at UVA, works with some of the Connecticut folks, just for full transparency on that. We do have many faculty that are engaged in global health activities, and from things like research to service delivery, education, medical education in particular. And I think, one of the perspectives that people will sometimes raise, and I think is a valid one, is concerns around brain drain. When there's opportunities for people to be able to, move across borders, and recognizing the substantial differences in pay, especially, that can drive some of that. I think that we see that we have people in our community that are from other places who have necessarily needed to move here, or have other incredibly compelling reasons that they've made Vermont home, or might want to make Vermont home. And it gets really hard for me to feel like I can stand in judgment of those reasons, recognizing that they're quite diverse. And so having the ability for people to be able to serve in the way that they were trained, and in the field that they're passionate about, recognizing there's always some broader risk of attracting the U.S. is a magnet, not Vermont specifically, but the U.S. is a magnet for pulling health professionals. And so I have heard folks raise concern anytime this type of legislation has been set up. I think that really makes it even more important to do this well and to be informed about the experience that other states have had. I see the trajectory of this as a direction that people are going across the U.S. And so having the opportunity to allow people to practice, some of which who are here as physicians who have received asylum or come over as refugees or come over through family ties, I think we could really use their expertise, and I think benefit from them becoming more formally part of the medical community.
Thank you. Any other questions? All right, well, thank you so much for joining and making time for us today. We really appreciate it.
You're welcome. Thank you.
Oh, okay. Jessa or Devin, or did you want Michael to go first? He's not here yet. Either way. Okay. Eating meeting.
Yeah, exactly. Good morning. Thank you very much for having me. Jessa Barnard, the Executive Director of the Vermont Medical Society. I will add our support to moving an alternative pathway to licensure forward. We understand and share the goals of the bill, especially with workforce shortages in Vermont across physician specialties. We support exploring all options that can increase the numbers of physicians while also ensuring safe and appropriate practice. And we appreciate that there's been a lot of discussion around this bill, even starting prior to the session, and we've appreciated all the discussions to date. I had not seen the Board of Medical Practice proposal yet, but I will say we do also support going in that direction. We really think the board has done a lot of important thinking. They are experts in training and licensure in Vermont, and if they, we defer really to their, we want to make sure that this is implementable and implemented well. And we feel we've participated in a lot of rulemaking processes with both the Board of Medical Practice and Department of Health. And I think they are very, they certainly welcome public feedback, have public hearings, and gather good information that way. I did just want to add that this was something that I wanted to look into as thinking about this bill. And I think the committee has now heard this and understands the distinction, but just to make sure it's clear, like the difference between the existing pathway and what this would provide is, again, I think you've heard the current standard pathway, even if you've graduated medical school outside of the US and you want to practice in the United States, you have to complete 3 years of a residency or postgraduate training in a US or Canadian program. And that actually Vermont has a lot of physicians who have been licensed through that pathway. 12% of licensed physicians in Vermont completed medical school outside of the United States, 13% of specialists, and 8% of primary care. So that is, folks who have completed medical school outside of the country are a really important part of our physician workforce already. The goals of state laws like 142 is to create an alternative where you completed your residency outside of the US, you're licensed outside of the US, and you're practicing. And now we want to have a pathway for you to come practice in Vermont. I think I did have some more detailed comments. They would be, I suppose, less relevant with the direction that the board is proposing, with deferring more to rulemaking, but I'll raise just a couple of them. Because I think this one's not been highlighted quite as much, where we would support a pathway as either the current language or the board's language would allow for both primary care and specialty care. There are needs in both areas, and also I think our primary care members are particularly sensitive. We've heard this discussion in the legislature, but when we've heard other states sometimes talking about this, it's kind of sold as a way to fill a primary care workforce need.
And our primary care members feel very strongly, any pathway, if we're thinking that folks are safe, appropriately licensed providers in primary care, it should also be an adequate or a good pathway for specialty care. We should build one pathway that's sufficient and that meets the expectations of whether you're in primary care or specialty care. There's been an undercurrent in some states that, primary care may be less complicated, less difficult. You don't, maybe we can be more flexible in primary care, but not specialty care. And our primary care clinicians, I will say, take some issue with that suggestion.
Wouldn't that be more of a specialty board problem than?
Yes,
state
exactly. Well, except I will say some states have specified in their statute that this is only available for primary care. Not that we have that in currently in 142, but some states have kind of added that as like you couldn't even get your license. But yeah, it would be both it could be a credentialing or a medical staff. It depends if a hospital or position requires board certification, which not all do. For example, some, I think more are moving in that direction, but for, at least until recently, for example, not all emergency departments required all emergency department physicians to be board certified. They might actually hire family physicians who had expertise in emergency medicine, but they didn't need their board certification. So that could really be dealt with at the hospital or medical staff credentialing level. And I think Mike Zimmer even made a comment the day before, that some hospitals even can even have a way to waive that in their bylaws for certain openings if they wanted to. You've heard some conversation and you've asked some good questions around what is referred to as the recency of practice requirement. How recently does somebody have to have experience practicing? We do believe as a general concept that some requirement for recency of practice is really important to demonstrating maintaining clinical skills. All other existing physician applicants are required to have engaged in active practice within 3 years prior to their application. I actually think this may be an area that is a good example of something that maybe it's ideal to defer to rulemaking, because I think our view is regardless of the standard picked, it should be evidence-based. Not an arbitrary number, but what number corresponds to appropriate clinical skills. So we support the concept. We think it's very important. I don't think I could tell you exactly what the right number is. I don't know that, the stakeholders have that perfect number at this point, but I think that could potentially be something the board could really dive into when they're looking at what other states have done and why, and what the data is behind their requirement for current physicians. If that is data-driven, evidence-based, that if you've been out of practice for longer than that, you may not have as many current skills, then I think that's important to take into account. I will just comment, again, the Department of Health and Board of Medical Practice are really the experts in this area, but we do support sufficient resources for the board to establish this pathway. One of our concerns being if they are not adequately resourced, the costs of running a board are really borne by the licensees and licensing fees. And we would be concerned that if there were a lot of resources needed and not a sufficient funding source or appropriations pathway, that would be borne by other licensees. And so we just want to make sure that the board can do the work needed to do this well. Those were the only comments I wanted to add. Thank you for picking the bill up, and thanks for having me in this morning.
Any questions for Jessa?
I don't know if it's a question for her or anybody, but we haven't really addressed that word funding. What the ideas? What is going to be needed for funding for implementing this?
Well,
It's a
there's a
study
fiscal
at
note.
point. It's a study right now, right? But eventually.
There's a fiscal note for the bill.
Okay.
So those 3 FTEs of the Board of Medical Practice is what they said they would need.
I would defer to the
But wouldn't,
Department of Health or board to add more detail.
but that would change based
It would
on the
might
study,
right.
and then they would have to come back to the legislature, and the next legislature would have to decide whether or not they want to appropriate funding to move forward, or am I kind of, or they might do a study and say, oh, this is easy. And then
Or we can piggyback on another state doing this work, some of it. And actually, I think that actually raised, I forgot that I wanted to raise, just I think I really appreciate the testimony you just heard and all of the thought that the medical center puts into how to help support licensees, and they have a very deliberate and well-established pathway for doing that. I just want to point out that we are not at this point talking about limiting this pathway to organizations that already have residency programs. So they are already, an organization that has a residency program is probably really very familiar with how to train trainees. If we're talking about smaller clinics, practices, that's really where the board needs to do a lot of work of supporting every organization who's supervising a provisional licensee, how to adequately supervise, how to ensure they're meeting standards, because not all of these organizations may be teaching organizations to date. So we do think that's important.
Yeah, and I think Dr. McNamara indicated that currently, right now, they do all this sort of evaluation.
Right. That's already built in because they're a training hospital. But a lot of the locations that might want to support such new licensees are not, and so would need that framework created for how to try to somewhat replicate that experience.
Okay, thank you.
Thank you very much.
Hi, Michael.
Hello.
Hi, how are you?
I'm pretty well. Thank you very much.
Thanks for
Sorry,
joining us.
my hair looks windswept. I was just running through the hospital, which it causes alarm. And I'm like, no, it's a legislative emergency. I'll be fine. But we're a good day at the hospital. We're about 80% full, and we've got 4 moms down in our birthing center. So just a really fun day to round around the hospital, which is one of the best parts of my job. So, but anyways,
Wait, I gotta
What?
interrupt you. You're doing rounds? I
Oh,
don't
well.
believe, I don't think you were a doctor, so
Oh yes, I'm not. And I don't play one on TV.
How many of those babies did you deliver yourself?
0.
Okay,
And
good,
the
good.
midwives will let me know exactly when it's a good time for me to chat, and then when no, we need our space. But to me, one of the interesting parts being a non-clinician running a hospital in FQHC is I cannot do what the clinicians do, but it's really important that senior management rounds. I mean, where you sit determines what you see in leadership, and I don't see anything in my office. So I have to get out there and talk to people that do the actual work to see what's going on. And we encourage our senior leaders to do the same. And we're actually trying to formalize that process so people can be very consistent and this is when you should expect to see us on the floor and how we do this. But I learn something each and every time on the floor. It's really joyful in that way. So
That's great.
So
Yeah, so we had you in today, wanted you to talk about S-142 and
course.
get your thoughts on it.
Thank you so much. I really appreciate being able to testify before the House Healthcare Committee on S-142. As you know, Gifford is a federally qualified health center and critical access hospital serving Orange County and the surrounding communities in central Vermont. Our organization's ability to fulfill its mission entirely depends on our ability to recruit and retain qualified providers. And so we support S-142. We operate on a pretty thin recruiting budget and a limited reach for talent. And so we have to really find creative solutions to try to build our workforce. And so S-142 has caught our eye as the kind of creative solution that might work for us. Internationally trained physicians bring not only clinical skills, but a totally different perspective on how to serve our populations. And we would like to have that as another arrow in our quiver when it comes to recruiting. It is amazing the difference that one clinician can make to a rural healthcare provider, whether it's in primary care or elsewhere in our organization. And so we support that 142 creates an alternative licensure pathway for internationally trained physicians. The need for physicians at Gifford generally in Vermont as well is quite high, as the committee knows. And I mean, I think for us, if we were able to get a glide path where this could be worked out in a way where the path is well delineated would be really, really helpful to what we do. I had discussions prior to the session and at the beginning part of the session with other advocates for this bill. And we talked about an analog where, we've taken chances before on people coming back to practice who maybe had not, been engaged in the practice of medicine for a period of time. And, we've felt comfortable supporting people. And we understand they need to put supports around folks and make sure that they have the training and whatnot and the on-ramp they need to be able to credibly and safely serve our communities. And we feel comfortable doing that. And we feel like this is a good analogy to that. So if we want to maintain the range of services that we provide our community, and make sure we serve all Vermonters regardless of their ability to pay as an FQHC, we just think that this would be an important additional resource over time to help Vermont's rural healthcare providers. That's my basic pitch, and we're excited that the legislature is in the nuts and bolts of how do we, make the pie bigger when it comes to recruiting. And I'd be happy to answer questions to the extent I can.
I actually have a question regarding Maple Mountain when and if it's up and running. We just heard from UVM that they have a path currently if you're accepted as a resident in their program from an international school. I'm wondering if Gifford had any thoughts around utilizing some of those slots for residency
We have
as an
not had that.
alternative pathway.
We have not had a specific conversation about using those residency slots for international physicians. We certainly can. We are doing job interviews right now for a program administrator for Maple Mountain because we're becoming more confident over time that this may happen. And so we can add that to the list of issues to explore in the program. I did have some experience when I was leading the FQHC in the Northeast Kingdom, particularly with dentists. We had several foreign-born dentists, and I will tell you that they provided awesome care. It was a lot of hurdles to get through with the visa process, and that has become more difficult over time, as you all know. But I've seen people from quite far away like create a lot of care and joy in their community in my previous role.
Thank you. Any questions for Michael?
Hi, Alyssa, it's Leslie.
Oh, yes. I'm sorry, Leslie, go ahead.
Of course.
Thank you. Thank you very much. I'm wondering if you have talked to your medical staff about doing this, as it seems like a lot of the supervision and programming would involve them, and wondering how that might look.
So we have talked about different pathways. We've talked about this in the context, as I just said, of people returning to practice, because the burden falls, you are 100% correct. The burden falls squarely on the shoulders of the existing medical staff. I think for us to participate meaningfully, we need to be close to completely staffed up, right? Because if what we learned in staffing people that are returning to practice, if you're trying to cover for open employment spots and mentoring someone back to practice, like that's too much, right? And so we've talked about the conditions needed to try to support people that are coming in a non-traditional way. So we've had those discussions at Gifford. I feel like if we know exactly who's coming and when, like we can put together a plan that would be successful.
If I may, do you imagine, and you may not have gotten this far, that the medical staff might get support in terms of time to mentor new, physicians like this or others coming in rather than being added on to their responsibilities?
I think that is something that we would definitely entertain. And because, of course, as part of the residency program, if you want to make that analogy, there would be some attending providers who would have their administrative hours increased to be able to provide that mentorship. And so you could imagine the same thing happening here. I don't want to get over my skis because I haven't talked about this with my medical staff, but in previous roles, I've talked about, hey, would it make a difference if we shared panels? Right. And if we could share panels in that way, you could maybe flex your time a little better. right? If you knew, hey, I'm going to bring this person along, but we're going to share a panel together, you might be able to flex your time a little more. And then get some coverage when you're using your earned time off or whatnot. So that's an idea that we'll probably talk a little bit more about over time.
Yeah, thank you. I appreciate that because there will be, I think the medical staff will be the ultimate responsible group in your, hospital that, as you say, will have to bear the responsibility of this. And I just want to be sure that that doesn't, on the one hand, put more burden and then reduce access, how that all fits together.
Well, Representative Goldman, that's something that's important to note, and it's something that happens as a matter of like due course in our business. And I'll give you a very specific example. We had a long time experienced nurse in the Dartmouth system become a nurse practitioner, and they hit it out of the park in interviews recently. But we had to go to our team and say, unless someone raises their hand and says, I want the task of helping bring this person up to speed, it's not responsible for us to offer this person a job right now, right? Like they need that support. We actually think they're going to be great. And they talked about it as a medical staff, and someone raised their hand and said, I would really like to do this. I thought this person was great. Because we're really careful about bringing on brand new advanced practice providers because they need support. This idea you can just drop them in is not going to be, you're not putting them in a position to succeed. So we have these conversations regularly, and we just had a mid-career professional change from RN to NP, and the medical staff raised their hand because they thought the person was going to be great. And so we're very excited about that. But it's not something that I can responsibly impose upon people. It's a discussion that we have to have as a group.
Thank you.
Daisy.
Michael, good to see you again. Thanks for joining us. I wonder, you've worn a lot of hats, if I recall, in your career in Vermont. And I'm wondering, I don't know if you've had a chance to look at some of the language requested by AHS or just hear the concept of kind of changing this bill a bit so that they do rulemaking and a more comprehensive review of how other states are doing this.
Mm-hmm.
Could you speak to that idea and whether you feel it's necessary?
I want to be really careful because I'm not well. So I've read the bill. I'm very wary of saying like that whether this is or is not needed. I want to be very careful that we're not creating obstacles that make the program unworkable. And so I worry a lot about that, but I don't feel comfortable opining like directly, like, hey, whether this is necessary or not. I would say, and Representative Burbica, that I think Vermont's healthcare organizations are capable of onboarding people, and they're capable of going to the Agency of Human Services and saying like, hey, either this is going to work or this is not going to work, because we have to do that now with certain clinicians, whether they're returning to practice or they've had some sort of finding with the medical board. And so we have experience with this. So sometimes when I hear the debate, I feel like we're making something sound novel that's probably less novel in practice. But I want to be careful because I haven't had the opportunity to talk to the agency about its concerns.
Yeah, understood. Thank you.
Thank you. Thanks, Michael, for joining us. And I'm really glad that recent cost-cutting measures has not resulted in you rounding on patients.
Yeah, that would be really bad.
These really are bad.
I will tell you one thing. When I first got here, there was a hospitalist that asked me to round with her, and she felt that the patients would be more comfortable if I was in scrubs. And so I put scrubs on, and I've never seen the nurses take so many pictures as when I was rounding in scrubs. But we walked out of one of the patients' room, and one of the patients said, "Geez, that big doctor was quiet." And I'm like, "Oh, you're good for you. I'm not qualified to give you any medical advice." But I play my part, and it's a lot of fun. So.
All right.
Good.
Well, thanks for joining us. Really appreciate it.
Thank you.
Yeah, thank you. And thanks for taking on workforce. We really appreciate everything you guys do wrestling with our workforce challenges.
Thank you.
So,
All right.
thank you. Take care.
Good morning.
Good morning.
Thank you, Devin Green, Vermont Association of Hospitals and Health Systems. I'll be Hopefully pretty quick. I don't have much more to add on to what was already said. VAS definitely supports this bill. We support anything that will help our workforce challenges. I do want to I want to underscore two things. One, Michael Costa was correct in saying that we do this sort of onboarding a lot. It could be a physician who's been out of practice for a couple of years or that sort of thing. And so I think we are equipped to take that on. And I know that I have brought this to our chief medical officers, and there are a number of hospitals that are really excited about this proposal. And so I think we do have the resources there, but it's certainly something to be careful and constructive about. And then two, I want to underscore what the Vermont Medical Society was saying about specialists and ensuring that I appreciate that this bill includes specialists, because when I met with the chief medical officers, they have been bringing up the challenges around recruiting specialists, and not only the regular recruiting challenges that we all face, but the sort of direction that the US is going into with, subspecialties within specialties not really working well for rural settings. So previously we would have an oncologist and they would serve cancer patients. And now it's, a specialty within the type of cancer, which isn't efficient for rural settings and sort of decreases access. So we really welcome additional perspectives from abroad where specialists may be more general than what the US is doing today. So overall, we support this. My main note on I have to take a look at the amendment and talk with my members about it, or the proposed amendment from VDH. But my note there is just, we would want to ensure that the timeline is the same. We would want this to be on track to be up and running as soon as possible. So that's all I have.
I know the language is new. I'm so sorry, everyone. I know the language is new, but maybe if you guys can review it over the weekend, just so we get weigh in on consensus.
Happy to do that.
All right, thank you. Oh, I'm sorry, did anyone have any questions for Devin? Yes.
Thank you.
Thanks, Devin. All right, we can go off. We'll be back here at 1:00. Have a good lunch, everybody, and we shouldn't be very long this afternoon.